Good afternoon. My name is Paweł Rajwa, and it's a great honor for me to welcome Professor Bertrand Tombal from Brussels, Belgium, and Professor Nicholas James from London, UK. Today we will talk about metastatic, synchronous metastatic hormone-sensitive prostate cancer. What are the treatment goals and what are the treatment options? So first of all, I would like to welcome you and ask. What are the key considerations when selecting treatment for men with synchronous metastatic prostate cancer, for whom you recommend triplet therapy, doublet, or monotherapy?
Go first.
Okay, so I think one of the striking things, if you look at population-based statistics, is that a large proportion of men are still getting singlet therapy, ADT only. And that applies in all high-income settings and even more so in low and middle-income settings. So I think the key thing is that a much higher proportion of men should be getting, at the very least, doublet therapy. And we've got a range of therapy options available that vary by country. I think the question of who should get triplet therapy, assuming triplet here means chemotherapy, not adding radiotherapy, then that's a much more contentious question. And that's driven by a lot of factors, fitness, volume of disease, and so on. So I think the case is strongest in men with high volume synchronous newly diagnosed disease. I think men with lower volume disease or metachronous disease, the case is weak or absent for triplet therapy.
Thank you very much.
For the triplet question, I like to think that it depends whether you believe the patient will need docetaxel or not one day. Because what we know as a fact, based on data, is that if you give docetaxel after ABI, ANZA, APA, even DARO, it's not working that great. So the question is really, what is the role of docetaxel in the management of metastatic prostate cancer today? Do you believe it still has a role or not? I believe it still has today. Like Nick says, in patients with very advanced disease, very aggressive disease, if you believe docetaxel has a role, then we have arguments showing that it doesn't work well afterwards. So why not to give it earlier when we have demonstrated that you can give it with no safety signal or whatever. Exactly. As for ADT monotherapy, I like the EMBARK trial, which is not metastatic, but basically show that the best agent is the AR pathway inhibitor. So we've done trial with ADT alone in metastatic patient, and it never showed a significant increase in overall survival. So it's not a matter of, if you want to go for monotherapy with ADT, you're probably giving a drug which is purely palliative. So I fully support what Nick says. Today, 2024, people should take it for granted that if you've got metastatic hormone-naive prostate cancer, you should receive at least a double treatment.
Yeah. And I think that the older, less fit patients, I think one of the things, I would very much agree, I think ADT is a very toxic therapy. If you're old and frail, if you lose muscle bulk and gain fat, you're going to start falling over, you're going to potentially die more quickly. And the oral anti-androgen therapies, I think, are long overdue a further re-evaluation as monotherapies in older, less fit men. And I think I strongly agree. The EMBARK trial is particularly interesting data in that regard.
Okay, thank you very much. So my second question is, so basically, how can you intensify treatment in men with metastatic hormone-sensitive prostate cancer? So how do you select patients, to intensify treatment in those men?
I mean, proven we're not going to start discussing patients who have metastasis on new imaging technology. That's more complex. But even though Stampede has shown that when you combine with radiotherapy, it is very high-risk patient. So to me, it's clear. Everybody should start, except if there is a major contraindication. Usually, when they have a major contraindication, like Nick says, maybe you should think of doing palliative treatment.
Yeah.
And beside that, I do reserve the triple for the very advanced cases.
Yeah, I just agree with that, really. I mean, I think it's important that people they need to be assessed holistically, in that that a lot of men, by the time they get to their 70s, in particular, which is the peak age of diagnosis, have significant other comorbidities. And one of the things that we've recently got data coming out from Stampede and from meta-analyses we've done shows that, for example, if you've got 2 or 3 cardiovascular risk factors, your risk of death in the next 5 years goes up. And the longer you live, the more the risk goes up. And if you then add an AR targeting therapy on top of ADT, you double the risk of death, for example. So we have to be very mindful that there are toxicities attached to these treatments that are not so apparent when you start using them, but they become more important over time.
That's a pride. You know, I remember when I started my career, I mean, somebody who would come up with PSA 1000 multiple bone metastases, he would consistently die within 1 to 2 years.
Yeah.
Now they live 5, 6, 7 years, and we start seeing them dying from something else.
Yeah.
The least is you don't want to be the one who actually accelerated that process.
Yeah.
So clearly, I believe we speak too much about high volume, low volume. We don't speak enough about comorbidities.
Yeah.
And that's where we're going to learn to individualize the treatment, choose well. You're never going to give ABI to somebody who just had a myocardial infarction. We know that with drug like APA-ENZA, if you've got somebody with Parkinson's disease, that can be like, can be like a catastrophe. So we're going to have to learn all of that.
And I think also bone health is really important. So coming back to your high volume patient diagnosed 10, 20 years ago, they didn't really live long enough for bone damage from the ADT to be a problem. Whereas, again, looking at data from Stampede, where we've hooked together the patient's data at diagnosis with their NHS records long term, it's very clear that very high numbers of these, maybe as many as 20%, are having significant orthopedic interventions by the time they get to 5 years, which they never used to get to before. And so I very strongly think that bone protection should be built into everybody's care if they're on long-term ADT now. And I think it's a really easy thing to do. An oral bisphosphonate once a week is all you need, calcium and vitamin D at the top. And potentially that will prevent a lot of harm later, because these people are going to live longer and longer and longer as therapies get better.
Oh, thank you very much. And do you still believe that ADT is a baseline treatment, or RC is I would say, it's becoming the first choice treatment, and then ADT should be like add-on?
I mean, if your question is, it's the baseline treatment, hence it could be used alone, I don't think we passed that point. I think that what we've shown consistently is, I don't know a single indication where adding RC or even using RC alone increased significantly endpoints. So one of the questions for the future will be, what is the remaining role of ADT? Who needs it? Who can be omitted from this? We are way, way, way too early to claim it's useless. I would say today the standard of care is still ADT plus an RC. But that's clearly one of the top academic questions we're going to have to answer in the next 15 years.
I think so. And there's a broader question around treatment de-escalation, in fact. So just coming back to the points I was making about cardiovascular disease and bone disease, the best way to stop those happening is to stop the treatment. And again, back in the day where patients with metastatic disease were dying within a few years, there's kind of no real opportunity to do it. But I think if you look at patients with low volume metastatic disease diagnosed today, they're probably going to be looking at median survival 7, 10 years. And do they really need to be on hormone therapy for all of that time? And the thing about moving to oral therapies without the injectables is that your underlying testosterone remains normal. So as soon as you stop the oral therapy, you're back to full-on testosterone. So it gives a much better route to intermittent therapy than starting on ADT. So I think there's a lot of interesting questions we're going to have to ask, A, around the treatment, and B, around stopping it. And with better imaging, I think I'm sure we both do this. We stop treatment, and it's 2-3 years in, their PSA 0, their scans are normal, we stop treatment, and then restart it when it goes up. And that's not been, I have to accept, properly tested in trials with contemporary therapies. But we know from the older intermittent therapy trials that it's probably safe. So it's probably safer now with better tools for monitoring.
And beyond the safety, it's also these optimization, de-escalation strategy are increasingly important to cope with the price of these drugs. I mean, if you go to middle-income countries where nobody can pay for 6 months of even generic ABI, I mean, it's even too expensive. Demonstrating that we can get the same effect with a shorter duration is important to make the drug affordable. So clearly there's still a lot of work to do to fine-tune the way we use this treatment.
Yeah, and just to pick up on that, so within Stampede abiraterone, we had two groups of patients. We had patients with high-risk locally advanced disease who got 2 years of therapy, and the metastatics who got indefinite therapy. And the striking thing is the hazard ratio for benefit on survival is the same in both groups, but the non-metastatics got much less treatment. And of course, we know, had we done PET scans of all of these, probably at least a third of them, or half maybe, I don't know exactly, obviously, but it would probably be metastatic in today's series. So I'm very confident we're over-treating people.
And that's typical of this new generation of drug, where what we don't know is the relationship between the intensity of the activity and the duration of the response.
Yeah.
People with antibiotics, they've sorted that out. They know you've got some antibiotics. What's important is the area under the curve. And the ADT not being very powerful, we show that a longer duration is better than a short duration. We have no clue whether it applies also for ARPA2 inhibitor. There are super interesting trials with immunotherapy who actually tend to show the opposite, where so we have to reassess all these shorter duration.
Yeah, no, I think it's really important. And the other thing, so we've just presenting this afternoon the findings of our Lancet Commission on Prostate Cancer, so looking at global issues in the coming 15 years. And one of the pieces of work we did was with some doctors in Brazil looking at the Brazilian healthcare system. And basically, if you're on long-term hormone therapy and you're paying for monthly or whatever Zoladex, the cost comes out as around $65 a month. In the Brazilian healthcare system, versus an orchiectomy, which is $85 just once. And if you make that switch from people who are on long-term ADT from injectables to orchiectomy, and transferred that money to buying generic abiraterone, you can buy and then give it at 250 mg daily instead of the full dose. You can pay for intensified therapy and save money and improve outcomes. It's a win for everyone, for the patients and the healthcare system.
You could even, and that's something many people don't know, but if you've been treating somebody with 2, 3, 4, I would say beyond 2 years of hormone therapy, I never repeat systematically the injection. I do what I call testosterone trigger re-injection, meaning that every 3 to 6 months, I monitor the PSA and the testosterone, extremely cheap, few euros. and then I see when the testosterone start rising again. First of all, for 50% of the patient, it never rises up again.
That's right.
So they are octectomized. And for the other, we do a repeat injection. And if you lose a long-term depot, like, triptorelin or leuproline long-term depot, you realize you're going to do an injection every 2 years.
Yeah.
With the same testosterone control. And that money, you save the money. Okay, it's cheap, it's €100, so that's why we have many patients coming from Central Africa say, you do one shot of, leuproline depot 6 months, and then you monitor your testosterone. All of that has to be put in practice if we want this treatment to be affordable.
Yeah, and I think the abiraterone example I highlighted, 250 mg of abiraterone with food is probably as good as a gram, and we've not really explored the dose-response relationships for these drugs. And so almost certainly there are other de-escalation strategies that we could look at that would give you the same outcomes at lower cost. And of course, pharmaceutical companies, for obvious reasons, are never going to do these studies. But governments could and should, because you can pay for the studies just in the drug cost savings, which they're paying anyway.
I have the last question. What is the role of radiation and metastasis-directed therapy in prostate cancer? This.
I'm gonna for radiation therapy. We have a controversy. We have a Stampede versus Piece 1, but I think that there's a lot to do because probably matter of dose. The question is, what do we expect from radiotherapy? Do we expect a local control, or do we expect like a, abscopal effect or something like that? So surgery, to be honest, I don't really see a role because
So my take would be slightly different to that. So I think the Stampede trial looked at radiotherapy and metastatic disease to the primary and showed improved survival in patients with low volume disease. Now, in the meantime, the standard of care has moved on to ADT plus an AR targeting drug. And those patients were included in piece one, but actually the numbers are much smaller. It's got 4 subgroups. But what you see in piece one is that most of the outcomes, but not survival, are improved in the triplet combination of ADT, abiraterone, and radiotherapy. But also very strikingly, and we've shown this in STAMPEDE as well, long-term urological complications are halved by upfront radiotherapy. So our practice at the Marsden has gone the opposite way. Actually, it's moved from low volume patients to higher volume patients with significant outflow problems as well. Plus we've incorporated the AR pathway inhibitors. And I think the data, we're never going to resolve it probably. We're not going to repeat STAMPEDE, RT and M1. Metastasis-directed therapy, we're just about, there's a number of trials going on looking at this, so we don't know. What I would point out though, so one of my research fellows has been looking at patterns of response and relapse in oligometastatic patients on PET, in patients not getting metastasis-directed therapy. And you would kind of predict that if metastasis-directed therapy was going to be really important, they would predominantly relapse at their sites of original disease. And it turns out they mostly don't. Only about 25% of them solely relapse at their original sites of disease. It's much more common to relapse at new sites of disease and not at the original site. So for me, it's definitely a live question. We shouldn't assume we should just zap all the mets at diagnosis and people benefit. I know people do, but I think it's very much unproven and needs testing properly.
And the bar is very high now. I mean, we were discussing like if you take a high risk, very high risk, STAMPEDE high risk that you treat with radiotherapy and 2 years of hormone and ABI, you've got more than 90% failure-free survival at 7 years.
Yeah.
So you would assume that the 10% are those with metastatic deposit and that you could save these 10% with metastatic. That's a very, very, very high bar. The study must be done.
The study absolutely must be done because you can always give SABR when they relapse to the ones who relapse. So it's not necessarily SABR or never have SABR, it's when do you give it. But almost certainly if you give it on relapse, you're going to be giving much less. You know, if we start sabering 5 metastases on everybody with prostate cancer, that's going to be very unpopular with our radiotherapy service planners.
And very expensive.
Okay, now last question. What do you think will be the treatment of metastatic hormone-sensitive prostate cancer in 10 years, 2034?
Well, I think to me it's going to be doublet with less ADT, different drug. You know, honestly, I want to see the result of the PARP inhibitor because I would be surprised we wouldn't see a benefit in the BRCA1, BRCA2. I want to see combination with radioligands and so it's going to be more combination. But I mean, probably, I'm not sure we're going to see as much docetaxel, and we're going to have to question the role of ADT as well. And then that's where we're going to see added benefit of local and metastatic targeted therapy. So I think it's going to be shorter, more intense, and better selected.
Yeah, I'd agree with that. I think we'll see 2 things, won't we? We'll see an intensification of treatment for the people with bad disease because they are still dying within a few years of diagnosis. But I think we will need to see a de-intensification of people with low burden disease because we are almost certainly over-treating most of these now. And exactly how that plays out will depend on the sorts of trials that Bertrand mentioned.
So basically, thank you very much for your time, for your expertise.
Pleasure.
It was a great honor to have you here. Thank you very much.
Thank you.
Thank you.